Good morning, good afternoon, everyone. Good evening. Thank you very much for the opportunity to present here today on early and long tuberculosis, which I gave the subtitle Through an Epidemiologist Lens. This is my conflict of interest statement. And what my goals are for this presentation is to give a broad brush epidemiologist view, because that's what I am. I'm not an immunologist, it's a disclaimer, on why tuberculosis takes so long and why only 5 to 10% of infectious progress ultimately to disease. And as you will see, I think those two questions are somehow interrelated. I will define a few research questions that could be addressed in the report studies and suggest an alternative approach to studying disease progression and protective immunity. We all know that there is a lot of interest in early tuberculosis and asymptomatic tuberculosis, which I think started with the observation that PET-CT lesions actually predict the progression to tuberculosis disease. And then later we also saw from the adolescent cohort study in South Africa that biomarker changes occurred already from 12 months before tuberculosis is diagnosed. And more recently, analyses of data from tuberculosis prevalence surveys showed that at least half of prevalent tuberculosis is asymptomatic, a bit depending on how that is defined. So that brings a number of policy relevant questions. Should we expand screening? Should we detect and treat earlier? Can we better predict who gets tuberculosis? And what does this all mean for protective immunity and vaccine development? I think all this relates to what happens early on in tuberculosis. And I still very much like this graphic by Paul Drain and co-authors at the time that here shows basically the trajectory of tuberculosis infections, especially here in the late phase, after the early phase of primary tuberculosis. Reactivation can be rapid, can be cyclic, can be slow, or latency can remain. And the early TB states that we are really interested in is this one of subclinical tuberculosis and this one of incipient tuberculosis in their terminology. And the two are basically defined by no clinical symptoms, and between the two by absence or presence of positive bacterial tests. More recently, there's been this international consensus for early tuberculosis, AIGHD, that defined conceptual states of infection and disease, and they basically distinguished no disease from disease, and they are distinguished by absence or presence of macroscopic pathology, and then disease is defined by symptoms being present, either subclinical or, as we would now say, asymptomatic, or symptoms being present, so clinical or symptomatic tuberculosis, and infectious or non-infectious tuberculosis, where infectiousness is defined as positive sputum bacteriological test. And basically the ones that we just mentioned, subclinical tuberculosis, infectious, that is asymptomatic tuberculosis, as just mentioned, and this is what we would have called incipient TB, but is now called incipient tuberculosis non-infectious because that's a bit of an awkward long term. I will stick to incipient TB, but are basically meaning the same thing. By thinking about these questions and the interrelatedness, I thought, as an epidemiologist, why actually does TB take so long? Now, this is the sort of classical way you would, in epidemiology, distinguish between the incubation period, no symptoms, and clinical infection. When the incubation starts with infection, the clinical infection starts when symptoms occur and ends without treatment, with resolution or death. And we know in tuberculosis, both can take months to years. Like we know, incubation period can be very long and it peaks somewhere in the first 2 years, but can actually be years. And this is from a modeling paper based on studies from the pre-chemotherapy era that actually suggested that of all those that have symptomatic tuberculosis, After 5 years, still 10 to 15% have tuberculosis. So indeed very long. So I thought let's look at other long diseases that we know of, and especially those with anthropogenic transmission. And this is diseases with a long incubation period, pragmatically defined as more than 3 months. Now, obviously, this list is not exhaustive, but these are important, globally important and prevalent diseases. Now, you can see these are parasitic infections, borrelia ulcer and leprosy, 2 mycobacterial infections, and then a few viral infections. And if you would then do the same thing for long symptom duration, again with a cutoff of 3 months, you see that these two overlap. That's to some extent they are the same infections. And there is the Helicobacter pylori is now added, and a number of infections down here. And it's important also to realize that this schematic here is actually very simple, because in terms of transmission there is a much more complex picture. Because for transmission we distinguish classically the latent period, in which there's no infectiousness, with the infectious period. And actually the onset of infectious period doesn't have to coincide with the onset of symptoms. Actually, very often we see pre-symptomatic infectiousness, where actually infectious period starts before clinical infection occurs. And this is, I think, best illustrated, the potential effects by coronaviruses. So this compares SARS-CoV-1, so this was the 2003 SARS epidemic, with COVID-19, so SARS-CoV-2. In SARS-CoV-1 infections, shedding, so infectiousness, doesn't occur until a number of days after the onset of symptoms. Very often these patients are quite ill, often already hospitalized, which is probably one of the reasons why this largely remained a hospital transmitted infection. Even though there were a few thousand cases, there was definitely not a pandemic. There was clearly a pandemic for SARS-CoV-2, and that was characterized by a peak of infectiousness in the 1 to 2 days before the onset of symptoms. So by the time people got symptoms, they had already been able to transmit to many others. And actually, those microorganisms that make it into pandemic microorganisms probably all pull this trick. In addition to this trick of pre-symptomatic infectiousness, there's yet another one. That is, make sure that from the pathogen perspective, that symptoms are not clearly recognizable or not continuous, so that contact, potentially infectious contact, can remain between the infectious patients and his or her environment. And if we then look at these two lists here, we can actually say, well, long incubation period and long symptom duration actually come together in just long infectiousness. And we can actually put these two together, and then we just have this list. And I think this is important because mycobacterium tuberculosis has a certain problem to solve. This is a very simple model of tuberculosis transmission, which starts with these people here are susceptible. They can get infected with a certain rate. They can have latent infection and then get fast progression to this I here. So this is disease where they are infectious, or they can have slow progression. Only 5 to 10% makes this step between latency and infectiousness. So only 5 to 10 progresses to infectiousness. Now, in order to achieve endemic equilibrium, where basically this effective reproduction number is 1, each infection needs to result in 10 to 20 secondary infections on average, and that's quite a lot. If you look at this list again, and I've already highlighted them for you, there is a certain pattern here, right? So the majority of these are actually sexually transmitted infections, and I think that tells us something. I think that TB behaves as an STI in terms of transmission, which is as an infection with restricted or time-restricted opportunity transmitting to a new host. So for STIs, the the restriction is primarily in the number of contacts, right? Only few people have a lot of contacts and are able to transmit to many others. But it's also usually in a time-restricted manner. Over a short period of time, you won't have an awful lot of contacts. So these diseases have to have, in order to be successful and maintain themselves in the population, have to have long periods of infectiousness. And I think TB, in a sense, that's the same thing. So from an evolutionary perspective, a long period of infectiousness, whether that be symptomatic or asymptomatic, may be beneficial or even necessary for Mycobacterium tuberculosis to sustain itself in the host population. And of course, it immediately begs the question, why then do only few infections lead to disease? My second question. I'll come back to that. But first, let's look at the implications of this for transmission. Now, I think this means that asymptomatic TB most likely contributes to transmission. But obviously, for practical purposes and for policy implications, we want to know how much. This has been addressed in a paper recently by John Emery from the London School, where he estimated that 2/3, 68% of global transmission could be due to asymptomatic tuberculosis. This was based on four studies from 4 different countries and modeling. Now, there is a problem with these data, and I think with any data that we currently have on the contribution of asymptomatic TB to transmission, which has to do with this. These studies almost invariably take a case contact approach. So they compare index cases that can be asymptomatic or symptomatic, and they compare them by looking at their close contacts, right? And they see how much tuberculosis or tuberculosis infection occurs in those close contacts. So it can be done only at baseline, which you see in some studies, by an infection test, such as AIGHD, or by diagnosing co-prevalent TB, and those studies that are more extensive, and in that sense, I think provide more valid results, do it again after a while, so they can actually look at incidence of infection over time and incident tuberculosis. But they suffer from a major problem, and that is that we implicitly assume that this duration between these two is similar. Because if the duration would be much longer in the asymptomatic index cases, which may well be true because they were not diagnosed, then actually this number of secondary cases is not a reflection of a difference in infectiousness. It may actually be just a reflection of duration of infections or difference in duration. And to make it more complex, it may actually be that symptomatic index cases had a period of asymptomatic TB before that, in which they were infectious. We don't know. And to make it even more complex, it may be that those who are classified as asymptomatic index cases actually had a period of symptomatic TB that was not recognized. It was never diagnosed. Just cough for a couple of weeks, nobody noticed, nobody bothered, but they were infectious. So I think that this design is not going to give us the answer. There's too much opportunity for bias and misclassification, and I think the only way in which we can get a definitive answer of this contribution is by doing intervention trials. Obviously, that cannot be done in a report, but there are a number of other, I think, important questions that can be answered related to this issue in report. One is, how important is cough for transmission? Because basically that's the only symptom that matters, doesn't it? Because that has to do with the fact that for a long time people thought that cough was necessary for transmission. But by now we know, for example, from Caroline Williams studies, but also studies from Cape Town, that that is not really necessary. Caroline Williams did these face mask studies in which MTB DNA captured was unrelated to cough frequency. A second question is, what is the sputum bacterial burden in asymptomatic TB? So how much actually have for example, smear-positive tuberculosis? Now, this is data from our own IPD meta-analysis that we did of 12 prevalence surveys, where we actually showed that 23% of TB cases in those surveys that did not report any cough were actually smear-positive. So cough doesn't matter. If you can transmit without cough, actually 23% would be in this population would be sort of highly infectious and probably transmitting. A third question is, what is the progression rate from smear negative to smear positive in asymptomatic TB. And the reason why this is important is illustrated by this results from modeling by the Johns Hopkins group recently that looked at the contribution to TB prevalence of different combinations of clinical state, subclinical, so asymptomatic versus clinical, and smear status, negative versus positive. And you see that, and in blue here, in blue is symptomatic, and in brownish is asymptomatic, and you see that smear negative subclinical tuberculosis, so this is based on TB prevalence surveys, asymptomatic smear negative tuberculosis is responsible for the largest proportion of TB prevalence. However, in modeling, transmission modeling, it contributes over a 5-year period only to a limited extent, as you can see here, transmission. But this depends on assumptions that the modelers make about these progression rates. And yet another question is, what is anyway the progression rate from asymptomatic to symptomatic TB? All we have at the moment is data from the same model by Alexander Richards from these pre-chemotherapy literature studies. And here on the left you see the breakdown for asymptomatic TB. But these progression rates here and regression rates are not based on empirical data. They're based on modeling of empirical data. So we don't have direct evidence for that either. And it is important. And I'll give you just one example why it is important, for example, policy. So this is work that we did with Jason Andrews at Stanford and tried to answer the question now, would it matter what the sensitivity and coverage would be of a screening test? So what is usually done is this low complexity kind of test. For example, a portable chest X-ray, which has high sensitivity, moderate specificity, but because it is still not something that can be done sort of underneath the mango tree, it will only have moderate population coverage. And we compare that to a near point of care test, for example here like a lateral flow test, that has an imperfect sensitivity. It is actually the same sensitivity as smear examination, but high specificity and high coverage. And what you're looking at here is the 10-year incidence reduction. On the left, universal screening. On the right, if people are first screened by symptoms and then by this test. I think the most important thing is to look on the left, on the universal screening. And in blue, this new near point of care test, and in red, the low complexity test. And you see that, and that is due to that you can get a higher coverage. I believe that here there's a 10 or 20% increased coverage that is modeled. You can see that the impact is actually higher of the near POC test. Same is true for mortality here in the second row. The interesting thing is here on the bottom is that the near POC test is actually much cheaper in terms of annual per capita cost for screening than the low complexity test. But all this again depends on the transition parameters that are being used in these models. So it's very important to have those. Now I turn to the second question. Why does only a minority of infections lead to disease? And I'm going to start with showing you a few conceptual models of early TB. And these are extremes, right? So you'll see. And in green, you will see the established infection. So those are IGRA positive or TST positive without any pathology. In blue, incipient tuberculosis, so that's without symptoms, bacteriologically negative. And in orange, TB disease, which it can either be with or without symptoms and is bacteriologically positive. Now, the first conceptual model is this one, in which we say, well, the 5 to 10% that progresses to disease goes through this period of incipient TB because we know that happens. But the remaining 90 to 95% actually immediately clear spontaneously their latent TB infection, so they don't get incipient TB at all. The second conceptual model is this one, in which we assume that everyone who doesn't progress to incipient TB remains latently infected. And actually all TB disease not comes from incipient TB, but also all incipient TB leads to TB disease. And then a third conceptual model is this one, in which all latent TB moves to any pathology, 100% develops any pathology, and out of that, over time, a certain proportion develops tuberculosis disease. Now, it's important to realize that only in this model there is regression possible, because here, clearance is clearance, right? You can't go back. And here we assume that once someone has been diagnosed, the diagnosis is made. So we won't be looking at whether there is spontaneous resolution later on. So only here regression is possible. Now, if you then think about conditions that increase disease progression, so I'm talking about HIV, malnutrition, diabetes, smoking, and so on. What would they lead to in these models? So in the first model, it must lead to reduced spontaneous clearance, right? Otherwise, can this not be bigger? In the second model, it must lead to either increased transition to incipient tuberculosis from latent TB, or to reduce regression from incipient TB back to latent TB. And in the third, it must lead to increased transition to TB disease. Now, if you look at the evidence that we have, I think there is quite some epidemiological data that suggests that the proportion of positive TSTs and IGRAs reflects spontaneous clearance. For example, the analysis that Marcel Beer did a couple of years ago of the distributions of incubation periods. And at the same time, we know from the few studies that have been done, even though they're small, that PET-CT scans predict progression to disease among recently exposed IGRA-positive contacts, but that spontaneous resolution occurs as well. This was, amongst others, data from Leicester in the UK in a recent paper. Which means, to me, that probably all these three models apply. So here you see them combined. Now, before looking at the implications, I want to look at this transition here, from incipient tuberculosis to the TB disease, and ask the question, how much incipient TB actually leads to the TB disease? Or put it the other way around, how much how much incipient TB was there before TB disease, right? So the best way to look at that is by looking at positive predictive value. So I think we have two leads. One lead is to look at biomarker signatures, for example, RNA prediction signatures. I think there's strong indication that they reflect this state of incipient tuberculosis. This is a study from a couple of years back by Rishi Gupta at UCL, who compared 8 RNA prediction signatures in an IPD meta-analysis, and these were the ones with the relatively high areas under the curve. And if he would assume a 2% tuberculosis progression rate, which means if he didn't have an additional test, 2% would progress, the positive predictive value for prediction of TB disease over a 6-month interval was somewhere between 10 and 15%, over a 6-month period around 10%, over a 3-month period around 15%. So that is only about 5 to 7 to 8 times higher than if you wouldn't have that test. So that's definitely not all of them, right? Only a relatively small minority. And we found the same thing in the recently completed PREFIT study, which was a case cohort study in 3 African countries with over 3,000 participants, where we did point-of-care prediction testing. And this is looking again at the positive predictive value at 2% TB progression rate for expert-HR, which is one of those signatures in this comparison, but now in a point-of-care test, and a CRP at a 10 milligram per liter cutoff. And you see the PPV is even lower. It's lower than 10%. And the Cortes trial has given us some clues about why this may be. The Cortes trial, as many of you know, was a trial in South Africa where the risk 11 prediction signature was applied to people in the community. Those that were positive were then randomized to receive tuberculosis preventive treatment or placebo. Now, in this trial, they looked over time at the signature response, and that turned out to wax and wane, and those changes turned out to be strongly affected by respiratory viral infections. So this all suggests that prediction biomarkers have a low specificity for incipient TB. There's all sorts of other reasons why those biomarkers come up positive in addition to incipient tuberculosis. But is it all just poor specificity and cross-reaction? Probably not. If you look at the PET-CT scan studies, I think the problem that we currently have is that only few studies have followed healthy IgG positive individuals with PET-CT lesions for disease progression. There are large cohort studies on the way. I know they're going to be, one of them is probably going to be presented in this meeting. I know they suggest relatively low PPV. Obviously, I can't give you any numbers, but they suggest also a relatively low positive predictive value. Whereas if you look at the diagnostic performance of PET-CT scanning, so these are people who have tuberculosis or don't have tuberculosis in a diagnostic study. This is from a systematic review, 13 studies only, different study population and different reference standards, so not necessarily straightforward to interpret, but it suggests that sensitivity is actually pretty high, sensitivity of PET-CT scan for having tuberculosis, and specificity is actually not that bad, somewhere between 70 and 80%. So to me this means that although for PET-CT the specificity for TB may be imperfect, as it is also imperfect for the biomarkers, the relatively low progression rate among those with PET-CT lesions, combined with relatively high specificity for diagnosis, suggests that only a subset progresses to the TB disease and that a resolution of incipient TB or PET-CT scan lesions is actually quite common. So why is this? Why doesn't all incipient TB progress to TB disease? Well, basically we don't know, but there are some clues, and those clues actually point to the idea that drivers of disease progression from incipient TB may actually be subtle tipping point effects that distort a delicate balance between host and pathogens. They've been called precipitators in a paper by Hanif Ismail, a term that I very much like. So some of the precipitators that have been suggested, for example, acute respiratory viral infections through increased type 1 interferon expression, drops in vitamin D levels through an effect on macrophages. That's one of the explanations for this strong seasonality in tuberculosis, and also why in Europe seasonality appears to be more pronounced in people with dark skin. Sudden malnutrition may play a role. There is evidence from, in the early days, gastric surgery, where malnutrition was very common and TB was very common, but also obviously from food shocks, as we know, for example, from a number of studies that have been doing during famines. What has also been suggested is actually MTB reinfection with a different strain, as that elicits a delayed type hypersensitivity response, which could have such a tipping point effect. Now, this is all speculative. So, back to our conceptual model. If this is the model, then it has two implications. One is that our estimates of TB progression are a composite of progression and regression rates between different states, right? So we have a certain percentage that clears spontaneously, that develops any pathology, a percentage that develops disease, a percentage that resolves their non-infectious pathology. So they're all quite different, right? And we take them as one in our progression rates. Implication 2 is that known drivers of TB disease may exert their effect on different transitions. So they may reduce spontaneous clearance. They may increase transition from latency to incipient TB. They may increase transition to TB disease, but they may also reduce regression from incipient TB. So quite different effects. Which to me means that we have a limitation with our current approach with regard to studying prediction biomarkers and protective immunity. So basically what we've done, what many studies have done, and this is from Dan Zach's paper, famous paper in The Lancet, for the predict signature, basically taking disease progressors in a cohort of people with latent tuberculosis and compare them to non-progressors, and do it in a training set, and then in a validation set, and then there is alignment to the time before TB diagnosis and so on. So basically it's comparing disease progressors to non-progressors. And as I said, that comparison captures very different effects. And the transition from incipient TB to TB disease, these tipping points, may actually be essentially unpredictable. They are very subtle things. So which may mean that we're basically looking at a combination of two things. We're looking at a combination of what I call predestinations, things we can predict, and just bad luck, which we can't predict. So and it may also mean that the transition from incipient TB to TB disease may, in addition, be unpreventable by any vaccine, because it's largely about bad luck, or at least partly about bad luck. You can't prevent bad luck by a vaccine. So incipient TB, rather than TB disease, may be the target that a vaccine, in order to be successful, needs to prevent or resolve. So an alternative way of studying prediction biomarkers and protective immunity might then be the following, which could potentially be done in a report. It is taking a TB diagnostic or treatment cohort and an infected contact cohort, and in both do both PET-CT scans and biomarker profiling. And out of that, come up with a validated biomarker signature for incipient TB, because clearly we can't do PET-CT scans on a large scale in all the different populations where we want to study this. And then apply that validated biomarker signature to large infected contact cohorts to answer a number of questions. What are the progression and regression rates for incipient TB? What are the progression rates for TB disease from incipient TB? What are the clinical determinants for each of these two? What are the immunological determinants for each of these two? For example, what is the immunological characteristics of those that regress from incipient TB to latent TB, because that's where we want to be. Now, obviously, you will have noted that I haven't answered this question, and I can't answer the question, but I have some ideas, and that comes down to this question here. What is the co-evolutionary benefit of sustaining a state of infection that is characterized by limited pathology but no transmission? From the perspective of the pathogen, it doesn't make sense. Why go through all this hassle and not be able to transmit to others? So maybe it makes sense from the host perspective. Could there be benefit to the human host in harboring actively multiplying M. tuberculosis, by which, from a population perspective, the 5 to 10% TB disease is just collateral damage? And that would then lead to the question, what are modifiable host benefits that enhance or sustain incipient tuberculosis? All right, my take-home message is at the end. First, the necessity for M. tuberculosis to produce 10 to 20 secondary infections on average to sustain itself in the population, host population, suggests that asymptomatic disease is important for transmission. 2. The contribution of asymptomatic TB to community transmission is difficult to establish, but better data on the importance of cough, sputum bacterial load, and transition rate from clinical status and bacterial load will be useful to inform policy choices for TB screening. 3. The mechanisms by which drivers of TB disease progression operate depend on our conceptual model. Most likely, it is a combination of spontaneous clearance, progression to and regression from incipient TB, and progression from incipient TB to TB disease. 4. Our current approach to studying disease progression, comparing progressors to non-progressors, is limited in that it combines these potentially very different effects. Studying progression to and regression from incipient TB may provide valuable insights. And 5, there may be evolutionary benefits to the human host, even if they're no longer relevant in this stage of evolution, right? But they may still be there, of harboring actively multiplying M. tuberculosis that may be worth studying. And with that, and acknowledging for the 2 studies that we were involved in ourselves, just mentioning the two study consortia and their funders, I would like to thank you for your attention.